Hello, Julian.
Hello, Mike.
How are you doing today?
I'm fine. I'm always fine when I see you, Mike. And you're looking well too.
Thank you very much indeed. Well, let's get on with recording the next episode of Veterinary Ramblings.
Let's go for it.
You had a tough day today?
It's another tough. They're all tough days, aren't they? They're all
They
tough
are
days.
at the moment.
Battle through this working field of life, but it's a fun day.
I sometimes I can't work out whether I'm on a Sunday, a Monday, or a Friday.
I think it's a Wednesday.
Okay.
So you're having problems there. It's a good day. I finished off my shirt. Look, there we go.
That's very nice too. I would have complimented you on it, but I didn't want to appear sexist. Did you make that yourself?
I made it myself.
Make that yourself, mate? Did you make your shirt yourself?
I made it myself. It's camouflage.
Beautiful. I love the greens and the blues and the swirls all around it. Is it a scrub shirt?
It's that basic design because I've never made anything like this before. So I had a scrub shirt that I knew fitted fairly well. Okay. And it was only made out of 4 pieces of material, 5 pieces of material. So
yep.
I traced around it with baking sheet.
Yep.
And cut that out and then put it onto the material and cut around that and then sewed it all together.
So are we going to have a sewing lesson tonight then?
No.
Okay.
No, because I have to put the sewing machine away.
Hi, I'm Mike Brampton.
And my name is Julian Ho.
Welcome to Veterinary Ramblings. What are we going to do? What are we going to do on the show then, Julian?
Well, I thought tonight we could have a chat to probably one of the most interesting veterinary nurses there is in the world.
All right.
I say that because we've spoken to a lot of veterinary nurses on this forum, and they're all amazing. All veterinary nurses are absolutely incredible. This one is interesting in that she's done pretty much everything. Sometimes twice. She graduated initially with a degree in pharmacology in 2002. Then she qualified as a veterinary nurse in 2005.
Right.
She did 10 years or so of locuming as a vet nurse, working in emergency clinics, referral practices, exotic centres, and spending time on the BVNA council.
That's British Veterinary Nurse Association.
That's it, yeah.
All right,
so,
okay. Yeah.
And that's how I met her, in fact, because we were involved in organising the British Veterinary Nurses Association Congress every year.
I'll ask her about that.
Yeah. And now, guess what she does?
Go on.
She rips organs out of living people. She does. Should I say she is the coordinator for the organ transplant system?
Wow.
Absolutely incredible. She's written numerous textbooks. She's involved in writing another one for BSAVA at the moment, which I'm writing with her. So I'm really, really excited to have Helen Ballantyne on with us tonight.
Wow. Okay. Well, actually, it looks as if she's here. So shall we get her in?
Let's get her in.
Okay. That sounds fantastic. Helen. Helen.
Hello.
Helen, you're measuring a cat.
And Lionel. Introduce you to Lionel.
Oh,
Lionel.
Hello, Lionel. And how tall is Lionel?
We're just playing today, not measuring.
Oh, I didn't know whether there was a sort of odd thing you did about this time every night. Right, time to measure the cat. Here we go.
We're all at it in Newmarket. Everyone's out measuring their cats.
I've got my dog down here, but I haven't got a ruler.
Is that a pun? Because dogs always are the ruler, aren't they?
Well, no, cats are the rulers, aren't they? They haven't forgotten what times are like in Egypt.
They know, don't they?
They know damn well that they're deities, aren't they?
I had to use a tape measure because otherwise it becomes bits of us. He sort of starts to jump and needs to chase things, and it becomes our fingers and nose, hair.
So you're currently working in the NHS, are you, Helen?
Yeah, that is the job really. I haven't done any clinical veterinary nursing for several years.
Right.
But I can't seem to shake it off. it's in, it's in me. So I keep my registration up, I do my CPD, and do some lecturing and writing and that kind of stuff. So
what's that book you're holding up? Veterinary Nursing Care Plans, Theory and Practice by Helen Ballantyne.
By me, absolutely.
Fantastic.
And this is absolutely the tone for veterinary nursing care plans. It not only talks about veterinary nursing care plans, it also talks about levels of competency and conscious, unconscious thought, reflection, etc., doesn't it, Helen?
Yeah.
It's an amazing book, a very, very all-encompassing book. And if you haven't got it, then I would go out and buy it, whether you're a vet nurse or not.
Are we going to have a tough time tonight with the CPD section?
Well, Helen has kind of promised, rather spontaneously, aka foolishly, to be our guinea pig for tonight, because we've just introduced in Veterinary Ramblings a new section called 60-second CPD. And Helen, I think I'm right in saying that you kind of, if not jumped at the chance, didn't crawl away from it too fast, and said that you might be able to do a 60-second CPD for us tonight.
Absolutely.
You fancy that, Helen?
Yeah, I've got about 130 slides, so I thought probably I could fit them. That would do, would it?
Yeah, that's fine. I'm just topping up.
Oh, hang on a minute. Yeah, I think I need a recall here.
Wait.
Hang on.
Isn't it always the way? You ask someone to speak for 40 minutes and they speak for 3 hours, and you're just like, stop. Yeah.
I was doing a talk for a local group a couple of months back on Zoom under lockdown. I was doing a talk on mushroom hunting to a retired professionals group, and about 40 minutes into it, they typically talk for about an hour. Yeah, about 40 minutes into it, someone cut in and said, I think you should finish now. Most of us are very tired. All right. Right. Anyone else want me to finish? Oh, yeah, I think so. Yeah. I don't mind carrying on. I'd like to finish. All right.
What did you have a vote?
No, I finished. And I said, look, if anyone wants to stay on, then they can do. And in fact, 5 people stayed on, which was great.
Oh. Do you have a clean client rule? So this was something I discovered in the NHS. So clients or patients, we call them patients. Yeah. Or if I'm getting muddled, sometimes I call them owners, which confuses people. But anyway, we don't do that quite so often now. So that's good.
I've got an owner.
Absolutely.
I have an owner.
Yeah.
I use that expression regularly. But I understand, because most people go, huh?
That's what happens to me when I say, I'll go and get the owners list. But
you mean the relatives?
Exactly. There's this expression where, if you walk into the staff room in an NHS hospital and there's lots of goodies on the table, there'll be somebody to tip you off as to whether they're sort of from people you think are clean or not.
Yeah, I always have this rule, and the nurses.
This is pre-COVID. No, we're not worried about sort of. No,
absolutely, I always have this rule. If someone brings in a cake, I say to the receptionists, please, for heaven's sake, examine their fingernails. And if they say, if I say, did you examine the fingernails? And they say, no, the cake goes in the bin. Sorry. Nothing to do with
Hang on. No. Whoa.
Yeah.
I've met some of your nursing team, and a lovely nursing team you've got as well.
Yes.
I've been told that the rule at your practice is that because of safety, nobody's allowed to eat the cake until you've had a slice.
Oh, it doesn't surprise me in the slightest.
Well, that may be a rule, yes.
You're doing them a favour, are you?
I like to think so.
That's the way you can try.
Sometimes it takes 4 or 5 slices to be absolutely certain.
Just checking it's not riddled with all sorts.
Yeah, it's great. And the other 6 of you can share this one slice.
Yeah.
It's a big slice, though, look.
Yeah.
So Helen, could you do this 60-second CPD for us?
Are we going to do this?
You do it.
What, right now?
Yeah.
If I could just clarify, the 60 seconds doesn't include question time. So,
No,
so if you set aside 5 seconds for question time, don't worry about that.
Yeah, because we did this in rehearsals, and I got to 58 seconds and ran out, and I wasn't allowed to ask for questions.
I see. So that's why. Right. I see. Fair enough.
That's the button. Yeah.
Okay, so Helen Ballantyne, let's have a 60-second CPD starting on 3, 2, 1, go.
So, as I've written a book about nursing care plans, it seems only sensible that my 60-second CPD is all about nursing care plans. Except nursing care plans are really a little bit too technical to sit into 60 seconds, which is now 45 seconds. So what I'm going to say is, I'm going to say, nurses, use nursing care plans, fill them in, think about them, write them down, talk about them, all that sort of thing. But most importantly, never take them for granted. Don't ever take anybody else's nursing care plan. Do your own. Get your baseline of your patient. Look at your patient. So either do your end of bed test if they're too scary to get them out of the kennel and look at them properly, or do their obs to make sure you know what their baseline is, because that's what nurses are really good at. They're really good at noticing the details, acting on them, and making patients all better. And it's all about the detail.
Wow!
And thank you. Thank you very much, Helen. That's fantastic. Nursing
1
care?
second to go.
It's brilliant.
Wow!
Brilliant.
Oh,
So-
we should do that. We should do that. All congresses should now be 60 seconds.
I can't shut the timer off. Wow, excellent. You covered something that's really close to my heart there, Helen. And it winds me through the roof. You and I haven't met, and so you probably don't know that I've got a particular interest in anaesthesia.
Okay.
And one of the things that I find most frustrating is that you get your patient on the table, on the operating table, and I'll say to the nurse that's doing the anaesthetic, not a small task by any manner of means, quite an important role. And I'll say to her, so what was normal for this dog or cat or whatever? And they go, so what's the baseline? Where were we before we induced anaesthesia? What is normal for this animal, so that we can try and keep a plane of anaesthesia and keep the physiology normal, or as normal as possible. And so many times I hear, I don't know.
Yeah.
And so that they refer to something like the BSAVA manual, and you'll find that normal respiration for a Labrador is between 12 and 20 breaths per minute. Great. Well, this one's breathing at 12. Oh, so that's normal. Well, no, because it was 20 when it came in.
Yeah, absolutely.
And they then sort of wonder why the capnograph is showing us such high readings. Well, perhaps it's because we've cut its respiration rate in half.
Yeah, absolutely.
And things like this. I mean, obviously, it's easier. You work in human medicine a lot now, don't you? That's your main role?
That's the main role now. Yeah, absolutely. Right. From a clinical point of view, definitely.
Okay, so I mean, it's relatively easy to measure Mrs. Jones's blood pressure, temperature, respiration rate, etc., and get those baseline obs, which of course is what our anaesthetists in the human field do. It's a little bit more difficult necessarily to get Mrs. Jones's Labrador's blood pressure, so maybe we've got to take that one as read.
Yeah, absolutely. But equally, funnily enough, we were having this conversation today about. So I do a lot of blood pressure measurements because half of my day job is I work with patients who have donated a kidney. So I walk them through the process of donating a kidney, either to someone they know or potentially altruistically. And if you have donated a kidney, you do actually have a very small, a small sort of increase in getting hypertension later on down the years. And so we do quite a lot of blood pressure monitoring. But, we now, much like in sort of the veterinary world, when I was sort of in it, we were starting to talk about white coat syndrome in animals and all that sort of stuff, will not start any medication for hypertension until we've got at-home readings. And I do these blood pressure measurements in the hospital, and I just think it's a complete waste of my time, because we're not going to act on them until they've gone home with a blood pressure monitor and demonstrated that when they're at home in their environment, they have still got hypertension. So it's, the same sort of issues apply, really. That baseline is just corrupted when you're in hospital.
Absolutely. Quick question for you on that, Helen. Do you use a manual or automatic technique on humans?
It depends what's sitting there in the room. Today it was a manual one.
Right.
Yeah, it's a manual one. Yeah. But it's an interesting one, because it depends on where you were taught. I had a matron, actually, who, when I was on one of my placements, refused to let any students use an automatic blood pressure machine. And we didn't like it very much, because of that. But because it's very time consuming compared to just, but it's I'm glad now, all these things, you're just always glad after that.
What I find particularly interesting with that, Helen, is that in human medicine, I think if I go back through my own career, and in a different life, I used to teach paramedics. And for our veterinary listeners, you won't recognise these particular qualifications. I'm ATLS, Advanced Trauma Life Support, and a CLS, Advanced Cardiac Life Support qualified.
Wow.
Wow. Not really, Helen?
Yeah, it's pretty good.
Yeah. Okay, fair enough.
Yeah.
That's why when I take up squash again, I want to play Mike, because I'm likely to have a heart attack.
Don't. My last patient didn't make it. That's another
quite,
story.
Do you manage to keep that up, that qualification? That's quite a qualification to do when you're not in practice.
No, it's gone, and truth be told, it was done as an NHS-TD, so it was an NHS qualification, or they were NHS qualifications, but because I never have been employed by the NHS-TD, in the rules and regulations according to, I don't know whether that's changed at all over the decades, that qualification can be kept up, but I cannot be certified because I cannot get private insurance to work on humans outside of the NHS. So to a certain extent, it was a personal interest, and it fitted with me training paramedics, because I was out riding on blue light calls with paramedics in real situations, and at that point,
I love the blue lights. I love riding on the blue lights.
Do you? Do you like that? What do you like about
that's
that?
That's my next, well, not my next, but one day I'd love to train to drive the blue lights. Yeah. So when
driving the blue lights, yes, very much. And as a oh gosh, this is a Mike.
It's a Mike show.
Institutes of Advanced Motorist Instructor.
I'd love to do that. I'd love to drive the blue lights. So I used to, one of my jobs, one of the parts of my jobs in Transplant was that I used to be part of the team that would go and get the organs, so go and get heart and lungs.
Now that's time critical, isn't it?
Yeah, absolutely time. So you've got, for a heart, you've got 4 hours from taking it from the donor to putting it into the recipient. And so it was blue lights, and one of the drivers who we used to go with, I would sit up front and he would tell me all about sort of what he was doing, all that sort of stuff. And I loved it. It was fabulous, really interesting. And then one of the other drivers, I would sit in the back with my hands like this, terrified.
my policeman buddy said, if you're driving on a motorway, there's no reason you should ever need the brakes.
No.
And I tried it once. I went on the M25, drove for 3 hours, didn't use the brakes once.
Yeah, that's probably because you didn't move.
I was doing 10 miles an hour. People were beeping me. It was horrific. I got goose. It was awful. So you're regional coordinator now for the.
Transplant Coordinator. So it's sort of what it does, what it says on the tin, really. So I coordinate transplants. So on an on-call shift, the offers of anybody who has been unfortunate enough to pass away in a situation where they're able to, their family or they are able to donate their organs, the organs, the information about the organs are then sent, and the donor are sent to me, and then I then speak to the relevant surgeon, and we sort of triage and have a think about whether they'd be suitable for any of our recipients, and then if they are, then there's a bit of a logistics game, so timings for theatre, getting staff and getting the potential recipient in from wherever they live, and matching blood transfusions, waking up lots of staff to get the job done, that sort of thing. So yeah.
Wow. So is blood typing your first arbiter on that one? Do you have a list of potential recipients?
Yeah.
So if you've got an O negative, for example, you know that organ is going to be applicable to a number of potential patients to receive.
Yeah, so absolutely right. Yeah, but so I think what we would always try and do is generally blood group match,
right.
and that's because there's reasons obviously with sort of antibodies and stuff, but even with the O's, and also actually I didn't realise, but if with the O groups, they can actually be, despite the fact that it's universal as it were, that people with an O group can be disadvantaged because the O's can go to anybody.
Yeah.
They're sharing their sort of pool, if it were. So there would be a match.
Negative, the universal donor.
Well, to be honest with you, I don't seem to be worried too much about positives and negatives. Actually, we don't seem to. We sort of say it, but nobody seems to worry too much about it.
Okay.
I am still learning, but no, nobody seems to worry too much about that.
Okay.
But yes, but also just as important would be we do some, depending on the organ and depending on the recipient, we'll do some age matching.
Right.
So probably one of the most important things with donor organs is the age of them.
Right. Okay.
So you would try quite hard not to put a 75-year-old liver into somebody who's much younger, or 80-year-old kidneys into a 25-year-old, that kind of thing. So you do that.
Me hoping that my donor card would be useful and I'd end up in some.
Yeah, absolutely.
And relive my teenage years, but obviously that's not going to be the case, is it?
Unfortunately not. No. And then a bit of size matching as well.
What were you suggesting about my liver there, Helen?
I'm sure it's beautiful liver. I'm sure it's a lovely liver.
It's well preserved. I've been doing my best. I mean,
cobblestone.
The whiskey that Graham Eckford gave us, which was decidedly formaldehyde.
It was ether.
Is that? Did he send that in the post to you?
Yeah.
I saw that little testing kits.
Yeah. So I have to say the post's been a bit remiss. I haven't received your gift today.
I got it.
Oh, right.
Did you not get yours?
No.
Thanks, Helen. Thanks so much. And the Fortnum hamper, I have to say, was just honestly that ham to die for.
I love one of those one day.
I don't even know what a Fortnum hamper is.
It's too expensive for the likes of us, Mike. That's what it is.
That's for sure, isn't it?
Do they still do MHC testing? The major histocompatibility complexes, or as anti-rejection drugs have become more sophisticated, is there less of an onus on complete matching? You look for a vague match and worry more about age and size.
So it's interesting. So it depends on the organ,
right?
Mm-hmm.
So kidneys we match closely, and we match kidneys very closely because the problem with not matching closely is that you can manage things with drugs, but then transplant kidneys don't last forever. So if you've got a 30-year-old who needs a kidney transplant, and you put a sort of so for example in the living kidney donor world, and you've got their sister wants to give them a kidney, and they sort of match. It'll probably be okay. We'll manage it with some medication, but it's not ideal. If that kidney then perhaps only lasts, well, could last sort of 15, 20, 25 years. But it still means that probably by 50, he's going to need a new kidney. And if he's had, that time with a kidney that wasn't great and wasn't mismatched, then he's going to be much harder to retransplant. And actually with kidneys, it's quite common to retransplant. And so the better match you can get, particularly for the first transplant, the better. And then interestingly with livers, it's blood group. And we don't sort of run the matching, which baffled me. Blood group and size.
Helen, you touched really very compassionately on the fact that in order for transplant to occur, people have to have passed away. People have to have donated. And you mentioned altruism. In the case of people giving their organs to someone who's not a relative. In fact, the algorithms they use to decide what organ goes where often means that the choice is out of the donor's hands to some extent, doesn't it?
So yes, absolutely. So with the deceased donor, there's no, it's not complete without. It's not without the realms of possibility. But so actually, funny enough, it's a question I get asked. So with people who are setting up a living kidney donation, it's quite an arduous process. They have to do lots of tests and that kind of thing. And it's not unusual for them to say to me halfway through the process, if I die tomorrow and my organs can be donated, can he have them? And actually, that's not something that happens. So you're absolutely right. The language is difficult because it's hard to describe, but essentially the organs go into a pool and a logarithm is applied so that the best possible match comes from using this incredible resource. So the donor and the donor family don't get any say in where a deceased organ would go. And that would be matched to try and make sure that it's used.
And I've looked at the math involved in trying to sort out which organ goes where, and it's hugely complicated, isn't it? Without computers, there'd be no way of working out.
And it changes. I think it's changed sort of since I've been in transplant, which is nearly 7-8 years now. So I think it starts off, and I find it very, very complex to kind of figure out. There's orders, so there's a the first kind of offering sequence depends on geography because time is of the essence. You have to get these organs done, and particularly the kidneys. The kidneys are very robust. They allow kind of up to 24 hours for kidneys, which having come from heart and lungs, where the timings are much shorter, that blew my mind completely. It's not unusual for kidney transplants to almost sort of do one or two after the other, and one of them to be waiting. So geography is important because you want to get them close. There's no point offering, a liver up in, I don't know, Inverness down to, John O'Groats or what have you. So it's John O'Groats in the south. I have got that right, haven't I?
John O'Groats is in the north.
It's in the north.
I've done that wrong. Scotland's a Cornwall. Let's do it that way.
Inverness to John O'Groats would probably still take you 4 hours because the road's a single track. I rode those. I've ridden that route on my bicycle, but
absolutely.
Very
So geography probably is one of the first things, and then like you say, there's a logarithm and a sequence that goes from there.
So are you good at geography, Helen?
I'm getting better.
I'm sorry.
We found something she's not good at. Fantastic, excellent. Everything else, the pharmacology, the veterinary nursing, the human nursing, transplant, the care plans, everything else, aces.
So one of the first arbiters then, I mean, you're obviously looking for preferential surgical outcomes. That's the key priority. So one of your first priorities is literally physical distance. It's geography between where the donor is and where the recipient is.
It's one of them.
One of them, right?
I wouldn't. There's nothing. It's always, and I think that's the beauty of this job, and it's the beauty of, it's the beauty of healthcare, isn't it? Generally, there's never a black and white answer, because if you've got somebody who's very sick, if you've got somebody who, if we don't get a liver, when I say we, I don't really do much with the livers, but if my colleagues don't get a liver in them in 24 hours, they're going to die. we'll take one from Inverness and fly it down.
Oh, right.
You know? So it's there's no. When I first started training, I would go to my line manager and say, right, tell me the ideal liver. This is I want to know what do they want? You know, if I get an offer comes through and it's got X, Y, and Z on it, is that what they want? And there just isn't an answer, because they could be in Glasgow and we're we're down here in the south, and actually for a patient that is, like I say, about to pass away, we'll take a gamble. It could be a donor that maybe isn't ideal. They've got some complications. They're sort of very over. If we're talking about livers, they're sort of overweight, or there's a long alcohol history. But actually, again, if the functionality is right, then the the organs potentially can be perfused artificially on a machine and tested out of the donor.
Very surreptitious drink.
And then potentially used, and whereas you wouldn't put them in someone who's at home and managing their liver or their kidney functionality okay, you would potentially you'd take the chance for someone who's very sick. So yeah, there's never a clear cut black and white, and it took me a while to kind of realize that, because I'm quite a black and white kind of person. I like my boxes and to tick them off, But
from a donor point of view, from the transplant point of view, there must be in those people who suffer this huge, this awful
horrendous loss.
There must be some sort of amelioration in the fact that their loss can go on to help someone else survive.
Yeah, definitely. I think that's very well documented. I think it takes a while, but I do think it's very well documented. And I think there's also a lot to be said for if siblings are left, if they know that the organs have been used. I think that can be a huge comfort as well. And I think it's really interesting, because we talk a lot about people on waiting lists and receiving organs and that kind of thing. But actually, just as much as I want to try and we want to try and match organs to the relevant recipient, I think the retrieval side of things, I'm always sort of on the side of the donor a little bit. They have made this incredible decision, and these families are, in all honesty, with my hand on my heart, these families hand their loved ones over to us, and the thing is that in their minds, unless they're medical, they're handing over their loved one who is still breathing, still heart beating, but his brainstem dead, and that's huge. That's a huge level of trust and a huge gift, and so you want to try and make sure that's used, and actually the families I always feel worst for actually are the families who go through this process, and because it adds time onto things. If the treatment is going to be withdrawn, then that's often delayed while they wait for the organs to be placed. And then sometimes the organs can't be used. And I feel it's those families that have been through all that extra trauma, because it can be traumatic, having to have these sorts of discussions, and then they have to walk away. And I always feel they're the ones that, when we used to go to retrieval, then we can't use the organs. I used to just my heart used to break for them, because I just think they've come so far and they haven't really got anything. But I mean, it's a weird world. And I used to come, so my sort of introduction to transplant was on cardiothoracic ITU, which is where I started in human nursing. Because I was coming into it a bit later, I thought, I'll dive in at the deep end, and went straight into cardiothoracic intensive care. And so I was looking after patients who'd had heart transplants, and also looking after patients who were waiting for heart transplants and on kind of artificial devices,
Yeah.
And the complexity of coming home and wishing that this patient would get a heart transplant, and then sitting on the sofa and thinking, I'm actually sitting here wishing for somebody young, fit, to have something dreadful happen so that my patient gets a heart, and you just have to stop.
You can't square that circle, can you?
No,
you cannot square that circle at all. You qualified as a veterinary nurse?
Yes.
Okay. So what took you into veterinary nursing?
Gosh, do you know, that's funny, isn't it? So it was just always there. It was just always there, right from the word go. And I think I was quite good at it. So I worked on a Saturday Girl in the local practice.
All right.
And an amazing practice. And do you know, even now I'm working with humans, the foundation that I got from that practice, I probably still use day to day. You know, I was in a meeting.
Do you want to give them a name drop?
Yeah, we can do. So it was Millhouse Veterinary Practice, Veterinary Hospital in Kings Lynn. So with David and Carol Clark.
Okay.
As they were at the time. And I was their Saturday Girl, and then went off to university and came back and realised I wanted to do something practical. So the pharmacology is fascinating, but I'm not patient enough to spend 5 years of my life, you know, trying to figure out one drug. And so then I trained with them, and then realised that I could do it quite well. Mm-hmm. And so then they trained me up, and then I sort of set off with a bucket list of what I wanted to do. Only one of which is still outstanding.
No, you can't do that thing. What's that?
So since I started lecturing, I wanted to lecture abroad. I've never done a lecture abroad.
Okay.
I'm close. I'm doing a US webinar not next week, the week after. So
wow.
Do that.
Look, just remember, everybody, you saw Helen first on Veterinary Ramblings.
So you're doing this webinar then?
Yes, yeah.
And that's on.
So care. Well, it's on sort of care plans, and there's also a little bit of sort of change management and leadership and that sort of stuff. So I think, you know, in the States they're really trying to, you know, the vet tech. Some of the vet techs are really highly qualified.
Yeah.
But I think sometimes there's like maybe potentially a little element of kind of a bit of task-based approach. So there's the idea is to do a little bit of, you know, kind of getting that relationship going, getting veterinary nurses or techs as they are to take a bit more responsibility and look at things a little bit more holistically and that kind of stuff. This is this session. So yeah, that's the plan.
Okay, excellent. And when is that?
So not next week, but the week after. So,
and who can get onto that webinar? Who can...
Well, anybody. I'm told. So I need to send some links out because yes, it's going through. Funny enough, it's going through. It's a nice story. So it's a meet cute really. It's the woman who reviewed the first draft of my book for the publisher. So she reviewed it and liked it, and then we kind of got in touch when I was allowed to know who she was, because of course it's all top secret at the beginning. And then we've kind of, you know, toed and froed and got a little network. We met one year at Congress, and yeah, it's been very nice. So. Yeah, it's their vet tech week. So yeah, they've got this sort of series of lectures. So yeah, so it's exciting.
Great. So our listeners and viewers could get onto the webinar as well, could they?
They could, if I could tell them how to and where it was. Then yes, they absolutely could.
We will share those details with you. Is it available for retro review type of thing?
I think it will be. Yeah.
So backtracking, Helen. See, you started off in veterinary, working at Millhouse Vet.
Yeah. So
what on earth made you want to qualify as a human nurse?
So a couple of things really. I think the first thing was that I think as I got a bit older, I realised that I liked people. Just as much as, and sometimes more than the animals. I was more in, you know, the people are fascinating. Oh, there's nothing like people. You
like
the owners.
No,
that's the thing I realised.
You get to like the bond, don't you? You get to you start off with the animals, and you think actually what's really interesting is there wouldn't be an animal here if there wasn't a bond.
So you had enough of puppy dogs.
Pretty much. I think it's one of those things, isn't it, where it sort of slowly came on, and I suppose it's a little bit romantic, really, but it's a calling. It sort of came over me, really, but equally, I think it would only be fair to say that there was, I'm fairly sort of ambitious, and I wanted to kind of be in a role that I found very challenging, and I think, this was 10 years ago, really. I started, God, let me just think, pretty much nearly 10 years ago, I started training as a human nurse, and actually back 10 years ago, right now, veterinary nursing in the UK in particular, I'm not so sure anywhere else really particularly, but in the UK, I know that, we've got nurses who are running practices, nurses who are partners in practices, we've got masters in veterinary nursing, there's nurses doing PhDs, we've got veterinary nursing directors in the corporates, that kind of thing. But actually 10 years ago, that career ladder was not necessarily there as openly, and I wanted something that would give me those opportunities. And also, I just think people are so interesting, So when I was at, I used to work at Papworth for a while, and when I was there, we'd look after patients that had pretty much exactly the same procedure, Mm-hmm. So the coronary artery bypass, practically they could be the same vessels, exactly, and yet the whole thing's completely different, and that's the beauty of humans, isn't it, in people.
So physiology is the same, the surgery is the same, so therefore treatment should be the same, isn't it? But it's not. It's vastly different, isn't it?
But it's not even, that's the point, I suppose, sort of, it's not even the same when you've got two human beings, is it? Because you could do the same surgery on two human beings and they will take different times to recover. A bit like you were saying earlier, some of them will draw up the covers to their neck, get in their beds, and they won't get out again. I brought a guy in for a kidney transplant a few months ago. So I rang him up and I said, look, we might have a kidney for you this afternoon. We need to come to the hospital. And so we did that, and that's fine. Now, this is a guy who's doing dialysis, but he's working. He's working, and he's been doing some DIY in his house. He got to the hospital at midday. I walked down the ward. He's in his bed. I said, "What are you doing in your bed?" He said, "Oh, well, I'm here for a kidney transplant." I said, "Yeah, I know. I'm Helen. I spoke to you. I brought you in. I gave you a call. Oh, yeah, I'm stuck on a February. You really don't need to be in bed. It would never occur to him in normal life to get into bed at midday in the afternoon, but because he's in a hospital, he gets into bed, And so I think the physiology, you're right, there is lots of similarities, but it's the detail, isn't it? And that's
is it the psychology rather than the physiology?
Yeah, and that all comes with it, isn't it? Yeah. Or it's it's so you do the same procedure on two people, but actually one of them's diabetic, or one of them's an endurance runner, so they're super fit, so they're out the door 3 days later, all that kind of stuff. It's these subtleties and these complexities that I think are so fascinating, and in animal patients and human patients, and also I think they're really the nurse's responsibility. Mm-hmm. I'm a real.
I agree, absolutely.
I think.
I guess it's no surprise that people are very different, is it? Our animal patients are very different. I did 2 cruciate surgeries yesterday, one on an English Bull Terrier and one on a Labrador. And the Labrador woke up and couldn't understand why it couldn't quite run out. The English Bull Terrier woke up and spent an hour and a half making the weirdest noises, like
what have you done to me?
Well, the Labrador wanted food, didn't it?
Yes.
Yeah, where's my dinner?
Where's my grub? Yeah, absolutely.
But so, what are your thoughts about doing transplants on dogs and cats?
Well, I think the thing is that and we talk to patients about this. So when I was working in cardiothoracic transplant, I would talk to patients about the transplant process, and I think you can't mollycoddle it. You can't kind of dress it up. This is no miracle cure. We swap your failing heart, liver, kidney, whatever it may be, for a good one. But there's a huge set of side effects that come with the medication. the likelihood that these people will end up with some form of cancer is very high because of the immunosuppression. With the heart medication, they often end up with coronary artery disease. So the arteries, the vessels of the heart fur up, as part of the general kind of process of chronic kind of rejection. There's any number of ongoing side effects that can have a real impact on people's quality of life. And so I think when it comes to animals, part of the reason that I ended up with people is that I've always struggled. I worked in Australia for a while, and in Australia, you've got these insects that have got enough poison to, drop a horse, and dogs and cats were getting bites from spiders, brown snakes or spiders. They would go into a respiratory or tick-borne disease. They go into a respiratory failure, and seeing kind of Rottweilers on ventilators and that kind of thing has never really sat long term because of medical. Personally, has never sat particularly well with me, just because I think it's very difficult to justify that because of all the side effects of that level of treatment with an animal. And I think it's the same with transplant. I can certainly see the ethical concerns because you're not curing them, you're swapping one set of symptoms for another, basically, when it comes to my experiences in human. And if that was replicated in animals, then I would question, I can see the ethical concerns, yeah.
I guess the big thing is we can chat to people, we can reason with them, we can give them some sort of mentation support, can't we? Yeah. And we can't do that with dogs and cats. And there's the question of how do we get some sort of agreement from the donor pet?
Yeah. And I think, it's so easy to. I mean, we do it at work. There's a lot of talk about surgical outcomes, but actually, and again, it's very often the nurses. I mean, I work with some amazing surgeons who take this all on board, but it's very easy to talk about surgical outcomes. So at 1 year, 80% of people are doing really well with their, are alive. At 5 years, 90% are alive, or whatever, whatever those numbers may be. But actually, in my mind, fair enough, 90% of them can be alive at 5 years' time. But, actually, if they're alive, but one of the kidneys failed and they're back on dialysis, what have we achieved? What's their quality of life?
Quality of life is the expression that springs to mind immediately.
And it's very, very difficult to quantify in people and animals. So I can certainly see the complexity and the concerns around it. I mean, when I tell people that they transplant kidneys in cats in America, I mean, some people just drop, what? And it's amazing. So people, we have a huge diversity of people that work at the hospital I'm at the moment, massive. I think we've got like representatives from sort of like 80 countries or something. And lots of cultures are not into having pets. So if they, I strike up a conversation and begin to talk about my background and what your cats and dogs can have done, some of these people are like, what?
One of my clients years back when I used to work in Wimbledon, one of my clients would have paid everything she had to save her pet rat, and it was a 2.5, 3-year-old rat with cancer. And I had to say to her, there's nothing I can do, but I've had a chat to friends of mine at the referral hospitals, and there's nothing they can do. And in their opinion, there is nothing that can be done. And she was bereft. And you may think, well, this is a rat. It's not important. This was her friend. This was her pet, her companion.
Companion, isn't it?
Would have given absolutely everything.
And I think the other thing I've learned over the years is that I remember a woman. I worked at the RSPCA hospital in London in Putney. I remember a woman who basically just couldn't sort of bring herself to have her dog put to sleep, and she was in the kennel with this dog, and she was absolutely. I can still remember the real kind of guttural sobs, and very often, not all the time, because sometimes it's companionship and family, isn't it? But actually, of course, when you dig a bit deeper, this was her son's dog, and the son had been killed in a car crash a year earlier. you know, and so that's the thing, isn't it? This sort of human-animal bond, and that's where I think I will never ever lose. And I almost feel like I only really got it when I left veterinary nursing. And you know, I've said this in other sort of sessions and lectures and things I've done, but you know, I remember it very distinctly. It was the day when I was in ITU, and I walked in, and I was a patient that I had, and really, really sick guy. He was on ECMO, and the wife had put up photographs, which is very common in an ITU room, you know, photographs of family and the grandchildren's graduation, and the chicken, you know, photo of the pet chicken was up, you know, next to the grandchildren and the wedding photo, and there's the pet chicken, you know. And I just looked at this chicken and thought, geez, you know, that to them is deemed as important as their grandson's graduation and other events, and that's what they want this man to see when he wakes up, is their pet chicken, you know. And I think it's, yeah, there is an irony that it was only really when I left that I really realised how important it is, I think.
We better not dwell too long on chickens, had we? Just to fill you in there, Helen, Julian and I have got a shared pond there.
Yes.
On one of my chickens, which was deemed terminal, and so it was decided that the decent thing would be done, and so Julian did the decent thing, and it was suggested that just to make sure, I wring its neck. Except I don't have the experience of how much force to use on wringing a chicken's neck. It's all right. Daisy's head went into the clinical waste with the rest of the body.
Easily done. Easily done.
It was complete.
Yeah.
Well, it was a job done. It was a job done.
No problem.
Yeah. Bless her. Bless her. She gave me a lot of very nice eggs, that particular girl.
Oh.
So,
more than enough.
So on that particular
on that bombshell
note,
or eggshell,
on that particular note, Julian, we've got CPD. Helen's delivered an amazing 1 minute CPD that took the whole course of this evening off in a completely different direction to the way I thought it was going to go.
Yep. But I have to say, Helen, we call it veterinary ramblings for a reason. You probably know that now. But we had a rough idea of what we wanted to ask you, and I don't think we've covered any of it, have we?
None of it.
No.
Oh God, give me one. What was one of them?
Well, no, I did. I covered one bit. I covered one bit because I wanted to explore although that all got lost, because I wanted to explore the qualifying as veterinary moving to the human side.
Yeah, and I wanted to cover One Health, which I know is very close to your heart.
One Health, we haven't even touched on that.
Well, we have though, haven't we? That's
we sort of have. We haven't
labelled it as One Health.
No. And to listeners and viewers, what One Health is the idea that actually, as Mike suggested and Helen corroborated, our physiology is very much the same as a dog's, as a cat's. Quite different from a goldfish, but you know, we have similar physiologies, and we can learn a lot from combining the experiences and the evidence of human medicine and veterinary medicine. The idea of One Health is to actually combine that knowledge to propel both academies of health, if you like, forward, both ideals of science and of medicine forward.
I think it goes further than that, though, Julian, because the whole One Health is acknowledging the role that each part, whether classified as animal or human, plays in the health and welfare of each other. So yes, there's the science thing.
The symbiosis between.
It's acknowledging the bond, the animal-human bond as well, I think.
Yeah.
I think, and then the step from that is to actually incorporate the environment in that as well. So as a sort of One Health triangle, really. So you bring in the environmental factors as well as the medicine and the animal. I sit on the I chair now. Blimey, I've just taken over from the great Simon Doherty, who was chair of the One Health, the UK One Health coordination group, which was set up as a result of BVA's Vet Futures. And
Really?
I've just taken on the chair, which is very, very exciting and very, very privileged to be asked to do that. And we
You
have
didn't
this
cover that in the
amazing-
introduction, Julian.
I
might not know.
didn't
You might
know.
not
I'm
know.
sorry,
No,
Helen.
you might. And this incredible group of people, sort of twice a year, sit in a room or on a computer as we do now. And you know, so we've got people who come from the National Trust, the Wildlife Trust, dentists, the medics come, the nurses. So we have someone from the RCN, from the Royal College of Nursing, and I'm sort of BVNA side and a bit of RCN as well. And you know, these things that these ideas and these sort of collaborations that happen are just absolutely amazing. You know, really, really, really fascinating.
Incredible. Well,
And we're living, aren't we, in a One Health environment? You know, COVID is a demonstration of One Health.
Yeah.
Yeah.
Wow.
Amazing. Wow. If ever I can be of any help to that with my wacky shirts or whatever, I'd be more than happy.
Wheel you in.
Do wheel me in. But however, I do have a CPD certificate for tonight.
Oh, fantastic. Let's see the CPD certificate tonight.
There you go. So
Has it got the 1 minute CPD on this?
it has. So this requires a bit of explanation. It says,
Okay.
it says Veterinary Ramblings does it again.
Well, of course.
This
We deliver
certifies
every week. Veterinary Ramblings delivering every single week with innovative and educational content with a hint of humour.
and more.
And more.
This certifies that Helen Ballantyne has given us 1 full hour of CPD compressed into 1 minute. And it says, how good is that?
Yeah.
And it's signed me and him.
Woo!
And now look, see what I've done is try and encompass Helen into this. And what if you don't mind me sort of putting in an old Roman lavatory, it's not meant. That's not. Don't read too much into that. What is saying that actually you've had an evolution of your life from some mainly old technology, brand new technology. There's one of what's that? That's an ultrasound. That is actually an ultrasound that I did to determine whether I should go ahead and do a cesarean.
Had you been drinking when you made this certificate?
Yeah, a little bit. So the pup was in fetal distress.
I'm sorry about the lavatory, Helen. I do apologise.
But this is technologically advanced for the age. This was the first Roman lavatory in England.
Have you come across the word tenuous, Julian?
Yes,
I love it. I'm going to take that as that you think that I'm advanced for the age. That's good. I like that.
And that's exactly it. I think you're
being very generous, Helen.
No, that's exactly the point, because actually Helen is pushing things forward. She's pushing technology forward in the evolution of veterinary nurses. And the question you use the word tenuous, after I ask you to tell me what that is.
Yeah. When once again you got into.
What are they?
Is that a CEP or is that?
Oh, it's mushrooms.
No, it might be a sulfur cap.
Killer mushrooms.
There you see. Now this is to show that actually we need to look deeper than the superficial view, because what those are potatoes. And I was using a spiralizer for my birthday. If you put a potato in the spiralizer and turn it a few times, the potato shaved off, and all we get left is those things that look a bit like mushrooms.
No, you are clearly showing everybody the picture of a mushroom. The question is what sort of mushroom?
It's not. They are potatoes that have been shaved off.
Yeah, right.
But what is this one in the corner? Is this a worm?
No, you see, this is a slow worm. And although a bit of it's been cut off by the printer, which wasn't working very well, what it's to show is we live in an era of infinite change. And so there's the infinity. This is a slow worm on my finger, you see. It's an era of change pointing towards technological advancement. And look, there you go. You've done it in a very comforting way. So here's my cat sitting on a bean bag, folded blanket, on another folded blanket. it.
I love this. Right, so I want a copy of this, but I need you to write on the back your explanation.
I'll write a full explanation. But I think you'd agree that that is probably the most tenuous, and I think you used the word very wisely there, Mike, the most tenuous set of photos I've ever heard on anything.
That's brilliant.
You are this close, millimeters or milliseconds away from being stuck in the waiting room.
I thought as much.
Bloody hell.
My God. But he'd never do it because he knows I'm right on this. He knows actually me doing this amazing CPD certificate, I'm completely immune to being put in the waiting room because he knows I'm right. I know when something's tenuous or not. And this
we'll see whether the RCVS accept this. And for all of our viewers and listeners, we'll be posting that on our Facebook page, Veterinary Ramblings on Facebook, for you to download and present that one to the RCVS at your peril.
Well, I'd because it will be valid provided you've complied with their regulation.
Of course.
You know, we've got to reflect on it.
We have to reflect, and I'm happy to reflect on Helen's contribution this evening because I think it's particularly valid. Whether your CPD certificate actually represents that is a whole different ballgame.
Don't reflect on that. I had a bit to drink.
Don't reflect on that. But Helen, would you join us for a moment to reflect, particularly on your spectacular 58-second, 1 minute CPD?
Short changes for 2 seconds. Never mind.
So please join us in a moment's reflection on the CPD this evening. You're not taking this very seriously, Helen.
Reflect. Good reflection.
Yeah, stop giggling.
We got the giggles last week, didn't we, Mike?
Did we? Oh, sorry.
Okay, I'm reflected. That's good. That's good.
Yeah, we've reflected on that. That's excellent. So there we go. So it's the time of the evening, everybody, where, of course, Julian is going to tell us a joke.
I'll bring the mood down. I'll tell a joke. And as always, I had a joke lined up, and then things moved on, and I thought, well, let's do another one. So I've got a joke about chickens.
You can't do that to me.
Oh yeah. So this is in fact, this is a joke about Mike, because a few years back, Mike was driving up north, and he'd been driving for a long, long time. It was on the M1, just past the Angel of the North, and he was getting a bit bleary-eyed. He thought,
that's the A1.
Even I that.
It's the A1. The A1. He thought, a bit bleary-eyed. Do I need to go to Barnard Castle to check my eyesight? He thought, no, I'll plug on. Not much longer till I get to my B&B for the night. And suddenly, in his rear-view mirror, he saw this thing, little bit like Roadrunner, coming up in his rear-view mirror. And this past him. He thought, well, that was a chicken. He looked down at his speedo. He was doing 70, no more than that, because the Institute of Advanced Drivers, he would never speed. He was doing exactly 70. And he thought, this chicken has just overtaken me, burning rubber, down the A1. And he looks at it in the distance, and it hoiks off left somewhere. He thinks, I'm going to catch it up, see what's going on. So he puts his foot down, still at 70, never above it. And he turns left into this little drive, and it turns out to be a farmyard. And there's all these chickens going, yum, 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 really, really quickly. He thinks, I've no idea what's going on here. So he knocks on the door. This farmer comes out and says, right, what are you doing? He says, I'm sorry to bother you, but I was driving up the A1. I thought it was the M1, but apparently it's the A1. And I've just seen a chicken overtake me, and he came into this farmyard. Now there's loads of them running around. He said, oh yeah, they're mine. He said, your chickens? Yeah, I bred them specially. He said, well, why are they so fast? He said, well, you see the ones actually that are just pecking food and are slow. You can count the legs. I'm like, it's 3 legs. He said, that's right. You've got 3 legs. Because I like a leg. My wife likes a leg, our daughter likes a leg, so I've bred these chickens with 3 legs. I use CRISPR technology. That's amazing. amazing. He said, what do they taste like? I said, no, the fuckers are too fast. Never caught one.
Oh, Julian, that is actually a funny joke for a change.
2 weeks running, because I think last week was.
Wow!
Hey, there we go.
I can't remember last week because I think I'd had too much gin.
I think I've got last
All
week.
blurs.
Last week wasn't good.
On that note, on that fabulous note, could I say, Helen Ballantyne, thank you so much for joining us on Veterinary Ramblings. I'll raise your glass to you. You can raise your cup of tea or whatever it is that you
Right here.
Thank you so much. Thank you so much.
Thank
so
you. You're
much
very
for
welcome.
joining us. If you like the show, click like, follow us, share, send it to your friends. I mean, there's some cracking stuff in this episode in particular. And may your dog go with you.
May your dog go with you.
Cheers.
Cheers. Thanks, Helen. Thank you so much.
You're very welcome. Had a great evening. I'm going to have to call it a night, gents.
Of course you are. Helen, thank you so much.
Oh, you're very welcome. I'll come back. If you ever get a gap, let me know and we'll come back and do some more.
Yeah,
Fantastic.
you'd be very, very welcome. I mean, it's been
Thank you.
I
Thank you
know
so
I've
much.
only just met you, but it's been a fabulous evening, and I felt we've really got an insight into you and your life.
Lovely. Good. Good. Thank you. What do I need to do now? Do I need to shall I just press the red button?
You press exit and go, and I'll speak to you soon.
Yes.
Take care, Helen.
Take care. Bye.
Good night,
Bye.
Helen. Thank
Bye.
you.
Bye.
Oof.
Isn't she amazing?
That was lovely.
Yeah.
Yeah, that was super.